Dear Chair, dear audience, welcome to the Progress Report. I'm Boglárka, or Túri, and my topic is altered vaginal flora during pregnancy. I'm a medical doctor at the Department of Obstetrics and Gynecology at Semmelweis University. I believe that pregnant women will have better outcomes due to professional prenatal care, and I would like to find new possibilities of screening and treatment of genital mycoplasmas during pregnancy. To complete this mission, currently I'm working on two ongoing projects closely related to each other, and I would like to conduct them both with a methodology of systematic review and meta-analysis. First, let me talk about my first project, which is investigating the effect of genital mycoplasmas on adverse pregnancy outcomes. The so-called genital mycoplasmas can be a part of the normal vaginal flora. Here you can see the prevalence of ureaplasma species and mycoplasma hominis is quite high. This is similar in pregnant and non-pregnant women. Mycoplasma genitalium is the only one recognized as an STI with a lower prevalence. Unfortunately, evidence-based guidelines currently have no recommendations on genital mycoplasmas, except for mycoplasma genitalium. The reason of that is the controversial data in the literature about pathogenicity. Nevertheless, there are plenty of adverse outcomes they can be related with during pregnancy, like preterm birth. Although all these complications are very dreadful for pregnant women, early detection could be able to prevent them. So my aim is to investigate interrelations between genital mycoplasmas and adverse pregnancy outcomes. To reach this aim, I chose this clinical question: do genital mycoplasmas increase the risk for adverse pregnancy outcomes? I'm going to investigate pregnant women. The exposure is genital mycoplasmas. The comparator is no genital mycoplasmas. And the outcomes are different adverse pregnancy outcomes. I hypothesize that pregnant women affected by genital mycoplasmas have higher risk for adverse pregnancy outcomes compared to those without genital mycoplasma infection. I've conducted a systematic search in 3 medical databases, and I ended up with more than 10,000 findings using this search key. After the duplicate removal and the selection of the articles, I was left with around 900 eligible full texts. As we have a large amount of data, we are going to perform multivariate analysis. This means that we are estimating the risk of preterm birth based on multiple factors, primarily the specific bacterial species, and secondarily other variables like the sampling site, the sampling time, the diagnostic method, the different co-infections, and the bacterial load. To form the basis of this, we have already performed univariate analysis for 9 outcomes of interest and several subgroups. That's what I'm going to present today. Based on the data of 161 observational studies, we are examining the association between genital mycoplasmas and different adverse pregnancy outcomes. We found a significant association between every species of genital mycoplasmas and our primary outcome, preterm birth. The first figure shows a summary table of the significant results related to ureaplasma species, including ureaplasma urealyticum, ureaplasma parvum, or both. They were all significantly associated with all secondary study outcomes as well. The highest risk increase was observed in case of PPROM. Here the odds ratio was 3.5, indicating that pregnant women infected with ureaplasma species have more than 3/4 chance for having preterm premature rupture of the membranes compared to those without genital mycoplasma infection. For the other outcomes, the risk ranged from 1.5 to 2.5 times higher. For mycoplasma hominis, we obtained significant results for 4 study outcomes. The highest risk increase was observed for a subgroup of preterm birth, specifically early preterm birth, with an odds ratio of 4. For mycoplasma genitalium, although that's the only species involved in guidelines, we observed significant results only for 3 outcomes of interest, although we found a strong association between mycoplasma genitalium and preterm premature rupture of the membranes with an odds ratio of nearly 15. Here we examine 3 variables simultaneously: preterm birth, ureaplasma species, and diagnostic method. Culture has lower sensitivity than PCR. It is able to detect higher bacterial levels. We obtained higher odds ratio with culture compared to PCR, which may suggest that higher bacterial levels are required for the outcome to occur. Here, the third variable is the bacterial load, measured in colony-forming units per milliliter with PCR. We established 3 threshold values: low as below 10 to the 4th, moderate as above 10 to the 4th, and high as above 10 to the 5th colony-forming units per milliliter. These figures show that the higher the bacterial load, the higher the odds ratio of the outcome, although we obtained significant results only in moderate bacterial levels. Here, the third variable is the sampling side, and it's clearly visible that the higher the infection ascends in the maternal body, from the vagina through the cervix into the amniotic cavity, the higher the odds ratio of the outcome. I would like to highlight the strengths of our study, which is the large number of articles available for 9 outcomes of interest, and we would like to perform multivariate and several subgroup analysis. However, I also have to highlight the limitations, which is the high heterogeneity, the presence of potential confounding factors, and the observational study design of the included articles. Our study suggests that genital mycoplasma infections are associated with several adverse pregnancy outcomes. Consequently, routine screening should be incorporated into practice. However, to confirm causality, there is a stringent need for new studies based on diagnostic molecular techniques and randomized treatment protocols with promising and safe antimicrobials. Here you can see the current progress of our project. Right now I'm writing the manuscript and shaping figures and tables. Briefly, let me introduce my second project, which is investigating the effect of genital mycoplasmas on adverse outcomes in pregnancies at risk for preterm birth. Preterm birth, meaning giving birth before the 37th week of gestation, affects 11% of pregnancies worldwide and being the leading cause of death in children under the age of 5. Numerous risk factors contribute to preterm birth. Among obstetrics conditions, preterm labor, which means regular contractions leading to cervical change before the 37th week, poses 50% risk for preterm birth. Preterm premature rupture of the membranes occurs when membranes rupture before the onset of labor, before the 37th week, results in preterm birth in half of the cases within 1 week. Women with short cervical length faces up 50% risk for preterm birth. Infections contribute to the half of preterm birth cases, with genital mycoplasmas being a key factor. Administration of prophylactic antibiotics in these conditions have not effectively reduced global preterm birth rates, highlighting the need for further research into the relation of genital mycoplasmas and adverse pregnancy outcomes in pregnancies at risk for preterm birth, which is my aim. This leads me to my clinical question. Do genital mycoplasmas increase the risk for adverse pregnancy outcomes in high-risk pregnancies? The population here is pregnant women with preterm labor, preterm premature rupture of the membranes, and cervical insufficiency. The exposure is genital mycoplasmas, and the comparator is no genital mycoplasmas, and the outcomes are interval to delivery, preterm birth, perinatal death, and chorioamnionitis. I hypothesize that pregnant women at high risk for preterm birth affected by genital mycoplasmas have shorter interval to delivery, higher risk for preterm birth, perinatal death, and chorioamnionitis compared to those without genital mycoplasma infection. By answering this question, I hope that our study could support practitioners in providing optimal management for high-risk individuals and utilizing effective antibiotic therapy to prolong pregnancy. We use the same search key and the same database as we did in our first project, restricted to the high-risk populations, and we are going to start the analysis soon. To summarize, here you can see my future plans. I would like to finish both my first project till May and the second one till September. Let me finish my presentation with a thought-provoking quotation by Mahatma Gandhi. Be the change that you wish to see in the world. Thank you for your attention.
Congratulations to the nice work you have done. So I have the ultimate question, like always, what is coming from the mouth and obstetrician. Okay, so according to your knowledge so far, what do you think, what is going to be the key, culture or PCR, when, and if we treat, then after that, how many times during the pregnancy we have to recheck, as I'm aware of it's coming back. So what do you see so far, according to your research, what is going to be the possible future here for recommendations?
So according to the recent results, culture would be better than PCR in the first project actually, so not at high-risk pregnancies, because it would detect higher levels and maybe higher levels are required for preterm births. So for your second part, when, we still don't know. We have some results about which trimester would be the best, but we do not have so much data about that, because in most of the cases they took the sample into trimesters, not in one. So these which we cannot use for the analysis. So we do not have significant results yet to this question one. And what was the last one? Sorry.
Whether we should, even if we treat it, I mean, if in the first trimester we have a positive mycoplasma, and after we treat it, should we recheck?
We do not have data about that, because in most of the studies they haven't rechecked these bacteria. Maybe if we would have more results about the trimesters, we would know that, but right now we do not know, unfortunately.
My question would be, based on the existing evidences, would you recommend to screen before pregnancy? I think the treatment would be easier and probably more effective.
Yeah, it would be worth it, but we have only 2 studies where endometrial sample was taken and that was checked, and it's not enough to say it exactly that to screen before that, but yes, you are right that it would be much easier, because in pregnancy we can give only a limited number of antibiotics.